So we're just 1 minute into the 12 o'clock. Do we, I'm not actually going to start right away. I'd like to wait a couple minutes at least to have more people here, but do we have somebody to read the land acknowledgement? We do?
Ellie, can you allow share screen?
Yes, Connor's going to be reading the land acknowledgement today. Thank you, Connor.
Okay. What else? One of the other things we had talked about when we were planning for this and future meetings was the possibility of, as a time-saving factor or tactic, only actually formally introducing verbally CAC members and everybody else introduce themselves in the chat. Did we ever make any progress on that? Or do we want to ask everybody today what they think about that?
I'll let you take the lead, Brad.
And just asking everybody?
Yeah, if you want to try that out today, or ask, and then depending on what folks think, try it out next month.
Okay. Yeah, we're just looking for ways to shave minutes, and we don't want to, obviously disrespect anybody or not be inclusive in the sense of having everybody vocally introduce themselves, but at the same time, it does take a lot of time. And we get to see each other in the breakouts. One other little caveat to that. Yeah.
This is Buffy. One of the other groups kind of made a statement at the beginning of the CAC meetings that was just kind of an open invitation to anyone who was new or who had changed roles, and then just asked everybody else if they could just kind of check in the chat. I don't know if that might be an option for you guys, but you might think about it.
Thanks, Buffy. Yeah, I mean, that would definitely save time, and I like that. I like that suggestion. Anybody else who's with us now have any thoughts on that? Okay. Is anybody opposed to this idea? And please, it's okay to be opposed to this idea. Just
what's the idea again, Brad?
We've been searching for and planning the CAC meetings, ways to be efficient with our time and looking for places to kind of save some time. And one of those places is introductions. It does take up a lot of time, and it's typically all the same people. Right. In our CAC meetings, occasionally we have new people. And so we talked about we had originally kind of talked about in a small group planning these meetings to only have CAC members, voting CAC members introduce themselves one by one vocally, and everybody else introduce themselves in the chat. And then Buffy just shared with us that one of the other CAC groups in the state goes even a little bit further and says, they invite anybody who's new or who's changed their role in their organization or to introduce themselves, verbally, and everyone else to introduce themselves in the chat.
Including the board members, or the CAC members themselves?
Yeah.
Yeah, I could support that.
Okay. Thanks. Anybody else have any input or? Mayra. Okay, well, let's go ahead and do that. Because most of us really do. We know each other. We meet every month. I guess if one other little caveat, if either anybody on the CAC, anybody in the meeting recognizes, like, let's say a CAC member or somebody who is typically with us, but maybe has been gone for several months, we could try to highlight them as well and give them a chance to say, hey, hello. All right, well, let's then I want to invite everybody to introduce yourselves in the chat, your name, and if you're associated with an organization, you could share that. If you're a consumer rep, you could share that. I believe, are we doing, yeah, we have, you'll notice in our names and our little tiles, our windows, if you see CAC in front of someone's name, that means they're a voting CAC member. And then there's some other COHC is the staff of the Health Council, and then guest. So that's very helpful. So pay attention to that, please. And so everyone, please introduce yourselves in the chat. But if you are new and we don't know you, Israel, I would call you out because I don't know you. So I would welcome you to introduce yourself, please.
My name is Israel Strada. I am a regional outreach coordinator for Southwest Oregon for the Oregon Health Insurance Marketplace. I'm new today because I'm covering for Carolyn, who is out. Carolyn Black, who is one of the regular attendee for this meeting.
Okay, well, thanks for being with us. Is there anybody else who's new or has changed roles? All right. Well, let's go ahead and move on. Is Connor with us? I can't see everybody. Can't I see everybody? Connor, you want to go ahead and read the land acknowledgement, please?
Yeah. We recognize and acknowledge the indigenous land on which we live, work, learn, play, and grow. This is the land of the Warm Springs, Wasco, Northern Paiute, Tenino, Klamath, Molalla, and Yahuskin. We acknowledge them as the past, present, and future caretakers of this land. It is on their traditional land where we partner to improve the health and well-being of Central Oregonians. We aspire to be good guests, honoring the concept in the Warm Springs culture. This land is for you to know and live upon and pass on to the children.
Thank you, Connor. Well, I would like to, now that everybody's introduced themselves, Connor has read the land acknowledgement for us. We've acknowledged the land that we live on, that we're meeting on. And I'd like to welcome Elizabeth Schmidt as our new vice chair of the Community Advisory Council.
Thank you.
I think everybody's already aware of that because you voted. So thanks for stepping up, Elizabeth. Elizabeth's been with the CAC since I can remember, and that's like years ago. I think maybe the only person who's maybe been here longer is Ken. Ken, you've been here a long time too. Yeah, the two of you I know have been on this for years and years. So thank you. Is there any public comment? Public comment, going once, going twice. All right. I know we do have a patient story, so Connor, you want to take it away?
Sure. So this is a brief patient story, and happy to answer any questions at the end. When I moved back to Oregon in late 2019, I needed to find a primary care provider. I was referred to one who had some specific experience in areas that I was looking for. This primary care provider was with Clinic A, a little over 30 miles from where I live, but I was willing to make that drive for the care I needed. The primary care provider was great, but towards the end of 21, they abruptly quit or retired. No one really knows why or what, and we were informed via letter saying that they were no longer seeing patients. And this was in the October-November month of last year. Clinic A assigned me a primary care physician within their clinic so my care could continue. And shortly thereafter, I was notified by Pacific Source that they had assigned me a primary care physician within that same clinic, but it was a different one from what Clinic A assigned me. I was notified by Pacific Source via a letter, and I called to inquire about the new provider. I told the rep that I was still looking for a primary care provider, which I have ultimately found in Clinic B, that would meet my needs, and that the Pacific Source rep said that that was fine, but that I was only allowed to change providers twice a year. I have since learned after last month's board meeting that was not correct, and that you are able to change it as needed. So that is good. Since Pacific Source assigned me a different primary care provider from Clinic A assigned, I had to reschedule my appointment so the primary care provider would be able to see me and get reimbursed. That was my understanding at the time, which I have since learned is not true as well, and that whatever provider I see, they will get paid, but they would like you to see the provider that is assigned to you. Having to reschedule wasn't a big deal, and while I appreciate Pacific Source being proactive, I would have liked some communication when it came to this decision, or Pacific Source offering to help me find a care provider that would meet my needs and care. And to sum it all up, healthcare is personal. While we try to be as efficient and cost-effective as possible, especially when we are dealing with a large population, we should do our best to remember that one size does not fit all, but it can fit most. We should try to be flexible and understanding of individuals' needs and help guide them through this healthcare journey. I don't know how realistic it is to reach out in a situation like this before making a decision, but I think a little conversation between parties can help ease the transition and uncertainty of change such as this. Any questions, or did I put you all to sleep?
No.
Brad, you're muted.
Thank you. I just was highlighting, calling out some of the chats. Stacy wrote, I agree. And somebody else said, thank you, Connor, for sharing your patient story.
And I did share it last week with the COHC board. And so that's where we got some of the answers to some of the issues that I had. So I ad-libbed a little bit during the story just to update with some information.
Yeah, it was great to have you at the board meeting. I think that's the ideal, I think, is when that patient story comes to the board directly from, when it's possible, directly from the patient. So thanks for doing that. One last chance to comment or say anything, ask questions about Connor's story. All right. So I want to remind everybody about our May 14th. I was just looking at it's May 14th, right? May 12th. May 12th, combined board and Community Health Council, Central Oregon Health Council board and Community Advisory Council meeting. Thursday, May 12th at 12:15 to 3:30 here at our Latino Community Association community room. So we're actually going to meet in person. Or if you can't meet in person, there will be an option to meet via Zoom. So we got a big screen here. The Health Council set up a nice audiovisual system so that we can try out this hybrid idea of having people here in person and meeting via Zoom. So I'm excited. I don't know about everybody else, but that's pretty exciting. That number one, we're going to meet in person, and that we're going to try out this hybrid approach, including everybody that can't, be here in person. So that, please have that on your calendar. It'd be great to have everybody there. I was very happy to see how many how many CAC members participated in our last meeting with the dental care organizations. I think it was a very successful meeting. Everybody's feedback says the same thing. All of your feedback expressed the same. It was a very rich and useful time that we spent together. And it's always better when all of us are there, or nearly all of us are there. So I just want to thank everybody for participating and contributing to that. And then we're going to meet with Gwen here shortly to kind of dig into that a little bit. Before we do that, we need to look at our notes from the last meeting from what month are we in? April, from our March meeting, and see if there are any questions, concerns about those notes, or would somebody like to suggest that we approve them as the official notes of our March meeting? Any comments about them? Everything look okay?
I move to approve if there are no comments.
Okay,
I'll second.
alrighty. Is anyone opposed to approving the minutes? We'll just go that route. Quick and dirty. No opposition? Okay, notes from our March meeting are approved as truthful. Excellent. All right. So now we're going to go into our breakout sessions. I hope we're all still enjoying the time that we get to spend together in smaller groups. For those of you who've never done this with us, we take 10 minutes to go into breakout rooms and smaller groups and just kind of connect with each other on a personal level before we get into our business.
Yeah, I'll
So here
send
we go.
everybody to their groups shortly in like the next minute. You should be there, and you'll have about, I don't know, 8 to 10 minutes to discuss. If you didn't need to sleep, what would you do with your extra time?
So, welcome back. We are going to go into a conversation. So hopefully that helped warm me up. So we're going to do a debrief about the DCO conversation that happened last month. Long story short, you all raised questions and concerns around periodontal and dental care. It's working its way through the emerging issues process that y'all helped develop. And last month, you had a 2-hour meeting with Capital Dental, Advantage Dental, ODS, OHA, Pacific Source, staff, and yourselves. We haven't had a chance to really debrief from that experience. So we're going to take 15 minutes or 20 minutes to debrief and identify any agreement y'all have on possible next steps to follow up from that conversation. So we're going to do this focused conversation style like we often do. So we're going to run through a series of questions that really help people focus, help people surface diverse thinking, different types of thinking styles. So we start with reviewing facts and information, move to some of the emotional responses that we have as humans to the conversation that happened. Then we go into a little bit of analysis and land on some decisional piece. So it makes space for all different types of thinkers and follows the natural thinking process. So in the meeting packet, I want to give you all a chance to kind of review the notes from the DCO conversation on your own. So I'll project it onto the screen for folks who would like it. And then I'll also encourage folks to go into your meeting packet and look over the notes. And we'll just turn off the screen for maybe 2 or 3 minutes for you to do a quick review and refresh your memory on that conversation. So feel free to do that. I'm going to mute and project screen. And we'll see you back here in just a few. Michaela just put the packet link in the chat. If you would like to access it, you can just click on the link and it'll take you to the packet online. I'd like to welcome folks back to the large group. If you are able to give me a thumbs up or turn on your screen just for a moment. A thumbs up, great. Thanks, Israel, Stacy. Excellent. How are you doing, Myra? I see your, thank you, Mandy, gotcha.
Sorry, I had ran to get a cup of water.
Oh, no worries, thanks, but you're here, we're good to go. All right, yeah. Thank you. So let's just start with some basics. In addition to what you review and remember from the notes, what else do you remember by way of facts? Things that happened. What else do you remember? And I'm just going to invite a couple people to share out on their own.
I think I was sharing earlier with my group, like, I think it was very surprising they were really open, very receptive of, information we were, questions you were asking. And so I was slightly surprised that they were very open to us.
There was a lot of openness. You remember a lot of openness and conversation, questions being asked and answered. One other person, what do you remember from other things that may have happened or conversation points or words or phrases that you remember from last month's conversation?
I remember the HERC, is it called, or that committee?
Yeah.
That interested me the most because it seemed like something might be accomplished, because I think it's a no-win system. I used to be an insurance adjuster and we paid medical bills at not 30%, but we were trying to get the employee back to work. And you could be sued for not paying the bill. So.
Yeah. So we learned, you heard a little bit more about HERC, the HERC, which is in the notes. Health something Review Committee.
Health Evidence Review Committee.
Commission. Health Evidence Review Commission. New acronym, new term, just to add to our giant list that already exists. Nice. All right. So moving forward, what was a high point for you in the conversation? Myra, you shared a little bit about the pleasant surprise of the openness. What else? What else was a pleasant surprise or a high point for you in the conversation?
I think that for me, when the meeting ended, I was more hopeful and encouraged and excited about future dialogue. I think we did a good job of listening and creating safety for both sides to admit vulnerabilities, not just to the system, but maybe some baggage that we both carry and a commitment to move forward. And I've been in healthcare for a long time, and it's one of the first meetings I've experienced with that level of trust and listening and respect.
Nice. Thanks, Linda. What other high points or positive things do you recognize? Stacy, could you share out in
Yeah, I don't remember the gentleman's name, but he did seem to, I don't want to say focus on, but mention more than once the social determinants of health of people who face barriers in properly being able to manage their dental health.
Yeah.
Yeah, to tag onto that, I think I'm talking about the same person, Stacy, but I'm not positive. But I think it was Manu Chaudhry with Capital that actually used the words that our system creates structural violence, which I was like, whoa. The head of a DCO, dental organization is he had a very unique, his story, having been on OHP himself and his family and everything else, and it was just very compelling. And then to use language like that and to see that he's leading one of these organizations, it gives me hope. But then the other thing he shared was that general dentists and hygienists can do periodontal care, and that to me was like, wait a minute. I mean, how many people know that? We're talking about this massive barrier that we don't have periodontists, but if general dentists and hygienists can do most of that work, then that just needs to be made, known. Consumers need to know that, and the providers need to know that. And obviously Pacific Source, we assume they know that, but they need to be telling our members that as well.
Yeah, so learning some more information that was new, having social determinants, all the barriers that impact care or access to care, getting care or following through with care being identified and honored in the conversation. What other high points, pleasant surprises did you have? Or maybe what was a low point or a struggle that you experienced in a conversation?
If I had that problem of needing that care and I heard the very few providers and that only 30% was being paid to a provider, I'd feel very depressed. I would feel like it's a no-win, but I could be wrong.
No, very disheartening to hear that. That folks caring for people most blocked from service or reimbursement so low. Yeah. Other low points or struggles?
So just learning how few periodontists we have in the state. That's not something that can be turned around quickly, but it is something that seems worth working towards.
Thanks, Ken. Yeah, recognizing the size of the deficit. Other impressions that y'all were left with, either positives or things that were challenging?
Something I learned was that some of I think it was maybe Capital and Advantage are starting like training programs for like maybe front desk staff to learn to become a dental assistant. And I thought that was kind of neat and something I didn't know before. So just wanted to share that.
Thanks, Kristen. Yeah, the continued work that they're doing. Everybody's trying to improve and provide broader services.
I think one question I had is, are other areas experiencing the issues as the same as we are, or where are those 35 periodontists located? And would it be better if we partnered with other CCOs and DCOs to tackle this versus just our little group here in Central Oregon? I don't know how good of a contact we have with these other organizations, but maybe having a collaborative meeting and discussing their issues to see if they align with ours. Maybe it's easier if we get more people on the same side of the boat rowing. And
yeah, great. And that's you got a couple of responses on the screen. You got some hearts, thumbs up, which really is a nice segue to the place where I know everybody's really wanting to go is given what was something that you learned or one insight. I've heard some of those. I've heard around the HERC. Connor, you highlighted the number and of folks, how it's impacting others, the high system level barriers. So what are some ideas, what other insights did you learn from this that might be applicable in identifying the next step?
I liked how, we heard all the barriers, and I felt like there was one individual who was like, this is our barrier, this is all we can do, the end. And then the other individual is like, okay, well, these are our barriers. This is how we're trying to lessen the effect and how we're trying to be preventative. So I would like to see, if we did connect to these other groups, what they're doing to work around the barriers, if they're doing anything, just general ideas that we could possibly adapt as well.
Mm-hmm. Thanks, Stacy.
Well, Tom Cosgrove meets with all the CAC members in the state. And I think in that meeting, that would be good to discuss this, to hear what because they represent all the CAC, and to hear what their problems are with this and their solutions. So that's a group we can meet with. I attend those meetings. I think Michaela does. And I think Linda does. So.
And I would love to have some feedback from the folks from OHA that participated in the meeting, just to hear from their perspective and their lens what possibilities showed up for them.
Yeah, this is Rebecca. I'm here today, but I think that Dr. Raffia would be more than willing to come and respond, to the group or provide some sort of written response, whatever would be most convenient and most informative to the group. He's very flexible, very willing. When I offered him the opportunity to participate, he immediately said yes. And I know that he felt like it was a really valuable conversation to participate in. So however you'd like feedback from him, I know he'd be willing to provide that.
Israel, I wanted to call out would you feel comfortable sharing out what you shared in the chat as a partner from another area of the state?
Yeah, so my region is Coos, Curry, Douglas, Jackson, Josephine, Klamath, Lake, and Lane counties. So definitely down there, the conversations haven't really steered too much towards dental, but they have mentioned that basically if you're not along the I-5 corridor, sometimes access to the other services, especially for dental, mental health, is just not as available as it is if you're like in the Valley or Eugene. Medford gets decent access because it is one of the larger population centers down there. But they definitely do have these issues there as well, where there's just not enough providers, especially when you're looking for specialists.
Thanks for sharing that in response to some of the earlier conversation about what might be happening and partnering with other regions. So any other ideas about next steps? We've heard reaching out, talking to other CACs, talking to CAC coordinator on the state CAC level, reaching out to Dr. Raffia and having additional conversation with him. What else comes to mind, if anything else?
One of the things I put into the chat is the Oregon Oral Health Collaborative. So that's a group made up of all of the DCOs, all of the dental care organizations, the schools, the different health systems, Kaiser, Providence. I'm not sure if St. Charles is participating, but a wide range of stakeholders that care about oral health, and they funded the development of the statewide oral health plan. And they also advocated for the dental director position that Dr. Raffia now holds at the state. There wasn't formally someone in a dental director position equal to a medical director for the state. And so Dr. Raffia's position was created. They also fund a number of different oral health initiatives around the state. And I should also mention that there's a number of funders that participate in the group: Meyer Memorial Trust, the Oregon Community Foundation, many of the health system foundations. And so I think that would be a really important group for this CAC to connect with. I think then there would be a way to sort of align with some of these conversations that are happening around funding of different dental projects, and also around funding for Medicaid and benefits and some of the workforce issues, because that group is very aligned with a lot of those conversations.
Great suggestion. Thanks you, Rebecca.
Huge. Let's see. Oh, Stacy, can you share what you put in the chat? And then we're gonna kind of transition to really formalizing what you want your next steps to be.
I just put that I shared after our meeting, I reached out to my public health professor and let her know of some of the barriers that the DCOs were facing. And she came up with a little bit of advocacy as far as in the CHW class, including OHA or oral health care videos, and where we had to get like a little certification in our course, along with some other resources. And she's also connected with Thrive here at the school, who part of our course as well is finding some more dental and oral health resources for people to add to their little book of resources at Thrive. So there's a little bit of stuff there. I just thought I'd update.
Thank you, Stacy. No, that's great. That's like on the ground, in the moment responses. Linda, you're asking in the chat, what feedback do we have from DCOs about the meeting and their thoughts on any steps? And I would, the staff haven't followed up with them, so I'll ask Kristen and Rebecca. Have you heard anything that you're able to share to that extent?
casually just that it was a really great meeting and that they're looking forward to next steps with the group. And so I think everyone is sort of kind of waiting to understand what we might consider doing going forward. I know that Dr. Raffia would like to know, what folks would like from him as something meaningful as a next step. So, but yeah, I felt it was a very good meeting.
I've also just heard very casually that the meeting was productive and, excuse me, well managed and yeah, respectful. And it seemed, productive. I certainly learned a lot of stuff that I didn't realize I didn't know. So I thought it went really well.
So we got just a few more minutes. I want to we've heard a lot of things through the veins of this conversation. So I'm looking for just y'all to be really specific on what are you saying that you want to do now? What are, you can put them in the chat or say it out loud. It'll kind of be the to-do list, I guess, of the next steps for y'all. So, but I want to hear from you all. What are you saying you want to do? What are the next steps?
Gwen, I'll jump in with one concrete thing that I don't know exactly. I just keep bringing it up because it was an aha moment for me, but it's not clear to me if it was also an aha moment for Pacific Source or OHA. But Dr. Chaudhry's statement that general dentists and hygienists can do periodontal care, that to me was like, okay, is that the way it's being practiced? Or is there some barrier there in terms of how when consumers or when like our dentists choosing not to do that work and therefore referring them to a periodontist specialist, or like, I guess I want clarity on that and to understand if that's truly the opportunity that it appears to be.
Sounds great. We'll put that on the list. Let's generate our list because we're almost out of time for this agenda item. What else? I've heard a few from some other folks. Go ahead, Elizabeth, Stacy. You all shared some specific ideas. Connor, you did too. So,
well, I'd like to say that is it called the CMS, the organization, the Federal Center for Medicare and Medicaid?
mm-hmm.
Well, I think we should contact them because I'm sure nationally this is a problem. And can't they change something? They have power, right?
Right. Okay. So you're at reaching out to some of those higher agencies.
Yes.
CMS, HERC, Dr. Raffia, Connor. There was quite a bit of conversation around one of the ideas you generated earlier.
Yeah, I mean, I wasn't very articulate, but I think reaching out to the other regions in Oregon and see if they have issues like us, and maybe we can partner with them to have a better conversation. And also, I think I would like to know where those 35 periodontists are. Are they concentrated in the Portland area versus, and see if, anyways.
Excellent. Yeah, no, that's great. You're totally understand what you're saying, Connor. You're just you're good. No worries. Yeah.
I think, like do another follow-up meeting with them. And after they heard us and what our concerns are, like, what are they going to do about it? Right. So they said, one was like, well, this is kind of where we're at. That's it. Right. And then the other one's like, well, we know that there's a problem. So I know for like the school system, they're short on teachers. So they're training teachers, right? They're growing their own. What about the dentist or, the periodontist? Like, we are short on them as well. So are they doing anything to get some to come into Oregon? Are they training more? Are they trying to grow their own? Like, what are we doing? Because we can't just be okay with 35, right? And be like, oh, it's what we have to deal with. Like, what are we doing about it?
Great. So more follow up on some of the stuff deficit areas. Linda, you said in the chat, compiling a list of specific issues that CAC agrees need some energy to pursue, and involving OHA, the state oral health program, and others in the problem resolution. So partnering in those. And then Rebecca, you offered some follow up with Dr. Raffia. So I think you've created a really good list to get us started. And staff will kind of follow up with y'all on next steps, and which of these, invite you all to be part of like what comes next and prioritizing these and reaching out, and also supporting the ongoing process with this. So, and follow the chat for some extra stuff. Thank you, Rebecca, for adding that. And with that, thank you for a great conversation, debrief, lots of exciting energy on advocating for preventative services in periodontal and dental care. And with that, I'm going to hand it over to Michaela for your next advocacy and social determinant of health support arena.
All right. I'll share my screen. Okay, it is that time of year again to start our next community health projects process. So I know you all just completed your 2021 process a month or so ago, but it is that time again to start the next. Fun stuff. Okay, so we only have about 15 minutes today. So what I have planned for us is to do just a little bit of a refresh, level setting on what community health projects are. And then there are kind of 3 big decisions that shape the community health projects process. And so today I just want to get a little bit of a pulse of kind of where we're at around, whether or not you want to narrow the focus on community health projects, if you want to set a project award cap or range, and then kind of what type of process you want for this, whether it's like a letter of interest, request for proposal, or request for application. Just kind of getting the pulse, seeing where there's already agreement or consensus around, and seeing where we need to have further conversation. And then lastly, I'm going to share a little bit about the community health project subgroup that met last week, and invite other CAC members to join if you'd like, and kind of what they're up to. Sound good? Okay. So starting with the community health projects overview. So community health projects, and if you were in the subgroup, you've already heard this, but community health projects are focused on improving population health and healthcare quality. And they're really focused on addressing social determinants of health and health equity. And social determinants of health are the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning, quality of life, outcomes, and risks. And on the screen are some examples of social determinants of health, from income to education, food insecurity, housing, early childhood development, access to affordable health services, and decent quality, which I would say kind of not just decent, but good quality. And what do community health projects do? They address social determinants of health. They improve health outcomes, reduce health disparities, promote the efficient use of resources. They need to support our current regional health improvement plan, so those 6 focus areas. Promote and increase wellness and health activities, and improve overall community well-being. There are some requirements for the projects that are funded. So like I've said before, they need to address social determinants of health and health equity. They have to align with our regional health improvement plan in those 6 focus areas in that plan. And they must take place within the geographic area of Crook, Deschutes, Jefferson, and Northern Klamath, and/or in the tribal nations of the Confederated Tribes of Warm Springs, Klamath tribes or the Cow Creek Band of Umpqua Tribe of Indians. And the projects must serve OHP members.
Michaela, I have a follow-up question on that. Do the projects need to serve only OHP members, or do OHP members need to be included in the pool of people served?
So OHP members need to be included in the pool. So the project doesn't need to exclusively serve OHP members, but needs to include OHP members. And restrictions for community health projects. The CAC can't fund any product or service that can be billed to any health insurance plan. Examples of that: durable medical equipment, screenings, medicines, things like that. They can't fund rental assistance, housing construction, and utilities. There's an asterisk because there's share funds that can cover some of that, but we'll talk about that at another time. Community health projects can't benefit a single individual or household. It really has to be at a community level. And it can't fund any project that doesn't address social determinants of health and health equity. And the projects, you can't fund a project that only serves undocumented community members. Undocumented community members can be included in the project, but can't solely address that specific population. Questions on that? Okay. So what it says in the contract with CAC and tribal involvement. So CCO, so Pacific Source, must ensure a role for the CAC and tribes in how health-related services, CBI spending, which is the community health project spending, decisions are made. And also identify the role of CAC and tribes in determining whether investments are made and what amounts should be invested in the community benefit initiative, or how we say community health projects. And the CAC has to be involved with tracking and reviewing of the spending, the community health project spending. So for the budget, we say each year the CAC should receive around $250,000 yearly. If you've been here the last couple of years, that number has grown. And that's really because we call the community health projects as kind of like an umbrella term, and it includes those community benefit initiative funds. But we also kind of pool together what's called quality incentive measure, social determinants of health spending funds as well. And there might be potential to include share funds in the future. So community health projects includes kind of those other pooled funds. And then also this year, there's a tribal carve out. So from the community benefit initiative, 25% of those funds will go to the tribes, and they will have that money to invest as they see fit. And all funds must be.
So this is Buffy. That's incorrect. So I just want to correct you.
Buffy, would you mind sharing a little bit?
Yeah, so there is a carve out for an opportunity for tribal nations to participate if they want, and that will be developed with each tribal nation. So I don't want the CAC to get the impression that the carve out is automatically going like a disbursement to the tribal nations. In order to support sovereignty and self-determination, there needs to be an invitation. And so right now, Pacific Source has extended that invitation to those tribes that work within our regions. And it is up to them to decide if they want to enter into that with Pacific Source or if they want to decline.
Thanks for that clarity.
And, yeah, and I can talk about, I had planned on, I didn't realize that you were going to go into this at this time. So I apologize, CAC, that I'm kind of just unprepared to have this discussion now. I had planned on actually presenting to you guys all exactly what took place and some of the methodology and the thought process behind it as a teaching moment. So I'll just leave it at that. So I apologize that I wasn't informed. Thank you.
Thanks, Buffy. Yeah, we can definitely dive into that, and we welcome that. So thank you.
Michaela, I just want to add one thing, that this is not unique to Central Oregon, that all 4 Pacific Source CCOs are extending this offer and invitation to the tribes at the same value. And those dollars do follow the same guidelines as CBI that you noted in the previous slides.
Thanks, Tricia. Okay, so community health projects, those funds must be allocated by the end of each year, so by December 31st. And so for this year, and I'm going to change it over to the budget. Buffy, Tricia, correct me, but the CAC has $345,000 of community health projects funds to invest. So just pay attention to the bolded bullet on the bottom. All right, questions?
I do have a question. If the tribes, for example, choose not to participate in some or all of the 115,000, what becomes of that 115,000?
You know, that I'll give Tricia and Buffy an opportunity to share, but you know, I think we might want to save that kind of in-depth conversation for another time and kind of get into the weeds of that, and what that looks like.
Yeah, I think that's a good call, Kayla. Buffy, do you have a jump in, or do you want to hold on that?
I think that what I would like to do is, since the conversation has been introduced the way it has, if the CAC members would take time to, you know, if you guys have questions, can you funnel them to either COHC staff or Brad, or even Tricia or myself directly, so that I can kind of gather them all up and make sure that when I have more information to share out, that I'm also addressing each of your guys' questions. Does that make sense?
All right. Yes.
The playbook is being created while we do this work, if you will. That's, I think, some of, but you know, we may not have the answers until we go through some of this process and then seek tribal input on those questions. So there is not a, yeah, we are building this while we are flying, if you will. So some things we know, but some things will be sort of unveiled throughout the process, I think, is a short way to answer some of that too.
Oh, sorry, I didn't realize that was long.
No worries. Any other questions on just community health projects? All right, so let's move on. We have just a couple minutes and we're going to do 3 quick polls. Again, this is just to kind of see where there's already agreement in these areas and where the CAC needs to have further discussion. But for the first item is around if the CAC wants to narrow the focus of the community health projects. With the CAC, you know, an example of narrowing that focus might be, you know, does the CAC want to select, you know, only one area of social determinants of health, or one population, or one, you know, some community in need. And last year, the CAC prioritized funding rural communities and most marginalized communities. And so we're wondering if the CAC wanted to do that again this year. We have if someone would kind of want to share their experience briefly of, you know, how that played out last year, just to kind of give some context before we do our poll. All right. I saw something in the chat. Okay, so let's move into the first poll. So this one's around narrowing focus. So if you're not a CAC member, I ask you to just click the red circle at the top. But for CAC members, this is the poll. So would you want to narrow the focus? Do you want to keep it broad? So remember, there is a little focus of it has to address social determinants of health and health equity. Or, you know, are there other suggestions?
And Michaela, just to be clear, would you consider a response of narrow focus to be, it's not more narrow than what we did this last time, it would be equivalent to what we did this last time, right? Some way of narrowing a broad, yeah, okay.
Would be anything more narrow than social determinants of health and health equity.
Okay.
In aligning with the RIP. And if anyone's having any issues with the poll, you can also put your answer in the chat and we'll make sure to include that. All right. Kelly, how are we doing?
We are good. We've had 9 members, which is all our CAC members today, respond.
Okay, so it looks like we're at 33% narrow focus, 56% broad focus, and then 11% other. So I'm going to read that as more conversation around this. And let's move on. Actually, we are a minute over, so maybe we should save these next 2 items for next time. So, but and we may, and we have to get going this, we may send out a follow-up email as well.
Michaela, I'm okay to do this in 10 if you want to take the next 3, if that's helpful.
That would be perfect. We have 2 more to go. Thanks, Tricia. Okay, so the next poll is around funded award range. So last year, the CAC wanted to set the award range at $5,000 to $80,000. So awards had to fall with, the project awards had to fall within that range. Does the CAC want to set another award range this year? Do you not want an award range? Kelly, would you mind pulling up the poll? So the first year you did 5 to 50, last year you did 5 to 80, and then there's an option for, you know, set a new minimum or set a new maximum.
Keep in mind the minimumist you may want to go is 5, because once you hit 5, it can go fall into another grant opportunity as well. So
Ooh, pretty even split. More conversation. Okay, let's go to the last one. So this one's around the whether or not you'd like to do a request for letters of interest, that 2-step process that you did last year, or having folks fill out kind of that longer application and not doing that 2-step. So on the left-hand side of the screen is just going straight, having people fill out that longer full application, and you're just sending out a request for proposal. The benefits to that is that that process, you know, it takes a short amount of time, and the applicants will kind of get their decision sooner than doing a 2-step process. It can be a little bit more burdensome on the applicants if they don't get selected. And there's more information for the CAC to review. Last year, you did a 2-step process where you asked for letters of interest. So kind of like that high level information of their project before inviting certain specific applicants to fill out that longer application, the ones that you kind of were more serious about funding. And again, that process takes longer to do. So the options on the screen, letter of interest, that's that 2-step. Request for proposal is everyone fills out, the long application at the get-go. And the request for application is if like you have a specific project in mind, say you want to fund sidewalks in Metolius, and the CAC wants to rally behind that and do that. That would be request for application, just one specific project that the CAC has in mind that you want to fund. And then additional suggestions at the end.
I have a question. Can you tell me if the current recipients were either debriefed or had a survey as to how the process went for them so that they could give feedback to the CAC?
So the applicants were not. Last meeting was the first meeting of the Community Health Project subgroup, and we went over kind of like the details of the Community Health Project, same information that was presented. But then there was some conversation, and someone else brought up that idea of, hey, we really need to survey our applicants to see how this process is going. So yes, I think that is a fantastic idea. And it looks like 67% is in favor of a letter of interest process. All right, so there might be just a little bit more follow-up conversation with that, but it looks like pretty good consensus. All right, I'm 1 minute over. I'm going to pass it over to Trisha. Thank you all.
You're muted, Trisha.
Thanks. Yeah, of course. That was my most brilliant, by the way. I was just saying, we can do this in 8 minutes. We did a dance party. So here we go. Let's go ahead and move to slide 2. And then I guess just as a caveat, we are talking about this. I mean, I think it's good information to hear and know. And I know that there are people in this space who have heard our executive vice president who does this work talk about this work, but it's also an OHA requirement that we discuss it. So here we are. Just a couple quick definitions. Fee for service is a payment model where services are paid for separately. So what this does is it incentivizes physicians to provide more treatments because it's dependent on quantity instead of quality of care. Value-based programs, or VBP, reward healthcare providers with incentive payments for the quality of care they provide to patients. And then the Learning and Action Network, also known as LAN, hang in there, we'll get there. I see your chat, thanks Connor. And the Learning and Action Network is a group of people dedicated to creating this process by which, let me get to my correct slide here, by which a measurement or a framework, Connor, is created. So we will talk about the LAN framework, and as a group of people who do this, and this is adopted by the Centers for Medicaid and Medicare, the CMS. Let's go to the next slide. So the reasons why we do value-based payments are really to meet our triple aim: better health, better care, and lower costs. Next. So why value-based payments? Again, this process of payments, it values both quality and lower costs in that space. And it's also really OHA's way, the Oregon Health authority of transforming healthcare. Oregon is one of only a few states that collects the data from health insurers like Pacific Source on how they pay healthcare providers outside of fee-for-service arrangements. And again, the value-based payments being the center of that model. If you're looking for more information in this space, you can go to, it's found in the Transformation Center of OHA's website. Again, it has a lot to do with healthcare transformation. And then I just think it's important to note that a successful transition and paying for value requires significant multi-sector system-wide collaboration. So let's talk about what this framework looks like. Connor, who jumped to slide 5. So we can go to the next slide. So I'm going to present this information in 2 ways quickly. I don't think it's critical that you really are understanding what land category things fall into. I think the important thing here is to understand that there's a spectrum of payments in this space, and the goal is to move towards a 4. So number 1 is the standard fee for service, has no link to quality of care. Number 2 is a bonus that pays for performance. So, hey, you did a pretty good job. They didn't come back 8 times the rest of that year. We're going to give you a little bit more money. And then there's a bonus and or downside risk. So that means if the provider doesn't do well, they could actually lose revenue in that space. And number 4 is a full, everything's tied to quality. There is no budget. There are no dollars that flow for services at all. And let me take you to the next slide, because I think this visual also explains that same thing. So category 1 is that typical, I hurt my foot, I go in, the doctor bills the insurance for my hurt foot. That's category 1. Category 2, you work down A, B, C. So category 2C is better than category 2A. Anything in category 3 is a better value-based payment, paying for value over quantity than category 2. And category 4 takes it to that next level, with 4C and 4N being the sort of ultimate goal. So if you were to draw, I really want to point on my screen, but I know you can't see me. If you drew an arrow across from 1 to 4, that's where we're trying to go. So hang tight, because we're going to get to how we're doing in Central Oregon. So let's go to the next slide. So Central Oregon, the main, let me get caught up on the main way we provide value-based payment is through a shared risk arrangement. That's a fancy word for contract. That contract is with St. Charles, Central Oregon Independent Practice Association, you also know as COIPA, Mosaic Medical, and the community mental health programs, which are Best Care and Deschutes County Behavioral Health. We're going to get there in 3 minutes, y'all. So here are some elements that are involved in what that looks like. So it's behavioral health integration. There are hospital quality measures, behavioral health, quality incentive measures. Those are some of the things that are components of it. Now here's the coolest part. St. Charles is in a land category 4 in Central Oregon. COIPA, Mosaic, and the community mental health providers are land category 3B within the same shared risk arrangement. So when you think back on the previous slide, 1 being, you know, hey, we're going to pay you for the serving the broken foot, but what if we did some therapy because we noticed your gait was off ahead of that foot being broken? Now we're starting to pay for value ahead of quantity. So let's go to the next slide and let me tell you what kind of percentages. So we have goals with the state for how to do this work. In 2020, and I have to apologize, it takes a while to get this data rolled in. So we only have data through 2020, but right now, notice we have 62% of our payments are in value-based arrangements. Our goal for 2020 was 20%. We are actually above the 2023 goal. So Central Oregon, as you know, the Central Oregon Health Council and Pacific Source have been partners with our community and doing this work for a long time. These are the benefits that come from that length of work. We got a minute left. Let's go to the next slide. So there are additional funds that are created in the shared risk arrangement. Those additional funds amongst the contract people in the room gets to be spent in really cool places. Here's a couple of places they're spent. The Deschutes Stabilization Center was at risk of closing. I think it was 11 p.m. to 5 a.m., might have been 4 a.m. This contract kept the stabilization open going forward in 2022 during those critical hours where somebody is experiencing a mental health crisis. They don't end up incarcerated, they go here. So it was really, really important. Let's go to the next slide. Great, here's an example. I'll tell you what, I think we've covered some of how this works, but it really just incentivizes providers to think about things differently. So if somebody comes into the office and they're having any sort of behavioral health issue, perhaps they can get a warm handoff to a therapist in that same building that's waiting. Why are they waiting? Because we pay. We've created a contract that allows them to have open appointments. So we pay for the value of that person being available instead of the quantity of how that works. I'm going to breathe. Does anyone have any questions in the last 30 seconds? You all are so lovely. Thank you so much for all your time and being here. If you go to the last slide, you can jot down my information. If you are digesting this later and we're like, whoa, I completely missed that. You know, it took me a while to prep for this, and I've seen probably 4 or 5 presentations like this. So, and I work in that contract space. I get a chance to observe those contract negotiations. So thank you all so much.
Thanks, Tricia. And I would just highlight Connor's question again. I had the same question. How is quality and or value measured? Like who determines if the care is quality or of value? And you can bring that back to us at our next meeting, or if people want to wait 1 minute to give you a chance to respond, we could do that.
Am I unmuted? I'm trying to figure out my screen. I mean, one way it's recognized is through, I mean, I think that's a great question, really. It put me at pause for a moment. I mean, one way we measure that is through decreased costs. So we know that value is being met, but I hear quality. How do we know that quality care? One way we would measure that might be fewer people smoking. Another way we might measure that would be more prenatal people getting dental care. Another way during maternity. Another way we might measure that is fewer ER visits, so that we know that the system is functioning in a value way to keep people out of the emergency room. Paul?
That is helpful. It just raises in my mind that, you know, if you're measuring, when you talk about like fewer people accessing a service, that could also be a problem. How do we know if it's a problem or a, you know, positive or negative thing? Would be interesting to explore.
Yes, whereas we would incentivize and, you know, providers to get people in for their well checks, right? That's a case where you would want volume high, but emergency room visits down because we're managing medications, we're looking at social determinants of health that may not be a billable space in the clinic. That kind of work being done ahead of ER visits, if you will.
Okay, I'm sure we can have more discussions about that, but anybody can reach out to Tricia directly if you have more questions about that. So thank you, everybody, for another great meeting and all your contributions and participation. And I think the next time we meet, we'll either be in person or virtually with the board and the CAC all together and meeting the new executive director and thanking and saying goodbye to Donna. All right. Have a great day. Have a great rest of the weekend. Take care.
Thanks. Bye.
Take care. Bye.